Good evening, folks. I've got discussion C for you tonight. We're discussing the portion of dementia that unfortunately shows up in one of the stages. Aggression shows up when later stage dementia. So let me clue everybody in, please, about aggression in dementia. Aggression in dementia refers to a cluster of distress behaviors: restlessness, pacing, irritability, shouting, resistance to care, or even aggression that emerges when progressive brain changes collide with everyday stressors. These behaviors are not intentional or difficult. They are expressions of discomforts, confusion, fear, or unmet needs. Understanding aggression through this lens shifts the focus from control to compassion, from reacting to behaviors to respond to the distress uh, under underneath them. What aggression looks like. Aggression rarely appears in a single form. It often unfolds as a pattern of escalating signals that caregivers can learn to recognize. Monitor or motor aggression: pacing, fidgeting, uh, uh, wringing hands, wandering, or repeatedly standing up and sitting down. Verbal aggression: shouting, calling out, repeating questions, cursing, or expressing fear or suspicion. Emotional aggression: sudden irritability, tearfulness, anxiety, or visible frustration. Resistance to care: putting away, pulling away during bathing or dressing, refusing medications, or becoming defensive when approached. These behaviors may ebb and flow throughout the day. Many people experience a predictable spike in the late afternoon or evening, known as sundowning, when fatigue, low lighting, and sensory overload converge. As dementia progresses, the threshold of aggression often lowers, making the person more sensitive to even minor disruptions. Why aggression happens. Aggression is best understood as the result of two interacting forces: neurological vulnerability. Dementia gradually uh, damages brain regions responsible for emotional regulation, sensory processing, memory, and impulse control. This means the person has fewer cognitive buffers to manage stress. They may misinterpret neutral situations as threatening. They cannot easily communicate comfort, uh, discomfort of needs. Small frustrations can feel overwhelming. This neurological fragility sets the stage for aggression but does not cause it alone. Modifiable triggers, everyday stressors can initiate aggression when layered on top of brain changes. Common triggers include physical discomfort, pain, constipation, urinary retention, hunger, dehydration, infection, or fatigue. Medication effects, interactions, sedatives, stimulants, or drugs that cause confusion. Environmental stress, loud noise, clutter, crowds, poor lighting, or unfamiliar surroundings. Emotional distress, loneliness, boredom, fear, grief over loss, abilities, or feeling rushed or pressured. Routine disruptions, new caregivers, schedule changes, travel, or unexpected visitors. Because many of these triggers are modifiable, caregivers can often reduce aggression by adjusting the environment or addressing unmet needs. Managing aggression. The, the, the guiding principle is clear. Start with non pharmacological strategies and address reversible causes first. Medications may help in rare, severe cases, but they carry risks and should never be the first line of response. Practical strategies, investigate physical causes. Look for pain, infection, constipation, hunger, dehydration, or medication changes. Treating these often reduces aggression dramatically. Stabilize routine. Uh, Predictability reduces anxiety. Keep meals, bathing, and sleep schedules consistent. Break tasks into small, manageable steps. reduce environmental triggers, lower background noise, improve lighting, reduce clutter, and avoid overstimulating settings. A calm space supports a calm mind. Use calm, validating communication. Speak slowly, use short sentences, and maintain a gentle tone. Validate feelings. I can see this is upsetting rather than correcting facts. Offer simple choices to preserve autonomy. Support emotional well being. Provide meaningful activities, music, familiar objects, gentle movement, time outdoors, or quiet companionship. Loneliness and boredom are powerful drivers of aggression. Redirect rather than confront. If a task triggers distress, step back, pause, and try again later. A small shift in timing or approach can prevent escalation. When medication is considered, medication is reserved for severe, persistent aggression that threatens safety and only after medical causes are ruled out. Environmental behavior, environmental and behavioral strategies have been tried, and a clinician evaluates risks and benefits. Even even then, the goal is to even then the goal is the lowest effective dose for the shortest possible time. Quick caregiver checklist. Rule out medical causes, pain, infection, constipation, dehydration, medication changes, adjust environment, quiet, familiar, well lit spaces, reduce clutter and noise, simplify interactions, one step at a time, avoid arguing, use gentle redirection. Support sleep routine. Support sleep and routine. Consider bedtime, daytime activity, limit caffeine and long naps. Document patterns, note time of day, triggers behaviors, and what calms the person. Build connection, offer reassurance, touch if welcomed, and familiar activities. Understanding aggression as a signal of distress rather than behavior to correct transforms caregiving. It empowers caregivers to become detectives, advocates, and companions, responding not to the aggression itself, but to the human need beneath it. Okay, guys, that's your C for tonight. I'll be back on with D shortly. Give me a bit for a break, and I'll be back on with you. Guys, thanks for watching. I'll be back on with D shortly.